All right, guys. Thank you all for coming out tonight. We're excited to have you guys here for this. There's some old faces who are friends of ours here and some new faces that we haven't had a chance to meet yet. So you guys are here to join us to learn about improving some of your odds for heart disease. I know most of you guys are here for that. Some of you guys, it's humid outside and you heard we had air conditioning, so you came and stopped in to cool off, which I appreciate that too. So hopefully you'll learn a little something as well with our time. So very excited to have you guys here. Everybody on Zoom watching as well too, as I met somebody else. All right. Very good. Okay. So the title of this presentation that we're going to do tonight is Improving Your Odds Against Heart Disease. Okay. We have an expert panel here with you today, which we'll introduce in a brief moment. And then we'll kind of tell you a little bit about, who we are as an organization and what we go through and do, and then hopefully give you guys a little bit of knowledge and some background that you can take some information with and, use that, internalize it, and hopefully, use it to make good decisions moving forward, or at least ask good questions. That's going to be the biggest thing. And hopefully we can answer some of those questions for you tonight. Okay. So really quickly, I'm just going to do a brief little introduction. My name is Mark Fida. I am the site leader and lead physical therapist here. I have a background in sports medicine and exercise physiology as well. My main discipline is physical therapy. So you're going to get to hear me kind of talk about some of the benefits of exercise and a few other recovery tips and tricks that I've kind of learned over my studies over the course of the year, or over my years, working and building my knowledge base. We have joining us via Zoom, and you can't really see her on here, unfortunately, but we have Francine Blinton, who is our registered dietitian. She works for us here at Performance Optimal Health. And Francine has a very long history of working with individuals with metabolic disease. So she is going to shed a lot of light on the nutritional aspects that we can all, benefit from and put into practice. Okay. On this side of the panel here, we have Dr. John Dinkler, who is a cardiologist, and he works for Consulting Cardiologists. They have multiple offices throughout Connecticut, and you're based out of Wallingford predominantly. Yeah. Do you want to just give these guys a little bit of brief background on yourself?
Sure. Yeah. So I'm from the blessed golden state of California. That's where I grew up in Southern California. I did my medical training in Boston at Boston University. I did internal medicine at the Brigham and Women's Hospital in Boston, and then cardiology at UCLA. And then my wife got a job out here at Yale, so we came out here about 10 years ago. So we've been in Connecticut 10 years, and I practice out of Wallingford, but I also have offices in Cheshire and Middletown as well. But our group is 15 different cardiologists. Most of us are non-invasive cardiologists, which just means we kind of generally practice cardiology broadly. There's a couple of interventional cardiologists in our group who are the doctors that put in stents and things like that. So, happy to be here tonight.
Very good. Thank you, sir. And then to his left, we have Dr. Ed Rappel. And Dr. Ed Rappel is internal medicine physician, owned his own practice for how many years, sir? 30 years, right? And now practices for internal medicine in Greater New Haven inside this building. And he is a close collaborating colleague of ours who we do a lot of work with. So Dr. Rappel, do you want to give these guys a little bit of background? And
sure. So I'm an internist. For clarification, that's basically the doctor for adults. We do comprehensive primary care, which essentially is 3 prongs. It's taking care of you when you're sick, acute care, chronic disease management, helping you manage the conditions on an ongoing basis, and preventive care, trying to prevent stuff before it happens. When it was my practice way back when, I was lucky enough to be Physician of the Year by Business New Haven magazine, sometime a decade ago. We had implemented electronic medical records about a decade prior to that, and using the technology, we were able to marry the best use of technology with face-to-face, one-on-one customized relationship with our patients to achieve a recognition commonly referred to as patient-centered medical home. it's a fancy long name, but they used to say that it can't be done in solo practice. And I was the first one in Connecticut to do it. And when we applied for that recognition again, it was on a 3-year cycle. We did it consecutively every 3 years for another 12 years. Essentially, what it boils down to is where every patient has an ongoing relationship with a primary care professional who is there to provide the services that I just mentioned. But it's also done in a way where things are culturally appropriate and taking into consideration the personal beliefs of patients, their families, and their caregivers. We take care of the whole patient. We don't just look at numbers on a lab test. I've done things where I went through and teach patients how to meditate. I've introduced hundreds of patients to Tai Chi. I myself am an avid exercise person, and I do a variety of different exercises, from walking to cardio intervals to weight training. I've done several years of Tai Chi training myself. Also a believer in utilizing the best elements of what we know about nutrition to optimize health, marrying that to exercise. By the way, I don't believe in diets. We can talk more about it as the conversation goes on. Answer questions later.
All right. Thank you, gentlemen. All right. So guys, we've got a really expert panel here for you this evening, and we're very much excited. So let's move forward. One thing that we'll go through and ask you guys, if you do have questions, we're going to have kind of intermittent stopping breaks throughout. So we just ask that you guys hold the questions up until those points. We will then engage you guys with any questions. So if you do want to write something down, if you need paper or anything like that, please just let us know, and Joanna can go and grab for you guys as well. For you all that are joining us online, we have the chat function that you guys can engage with, and Joanna monitoring the chat as well. So she will be able to convey those to us. So let's get rolling. Okay. All right. So let's get rolling. Let's get rolling. Okay. Let's get rolling. Okay. There we are. All right. So you're inside the walls of Performance Optimal Health. All right. So very quickly of who we are as an organization. We are a team of multidisciplinary professionals working together in collaboration to help the patient out, essentially the client out. Okay. It's a continuum. All right. So we stand here on the 4 pillars of what we consider optimal health to be, which essentially is exercise, nutrition, stress management, and recovery. We'll talk a little bit more about those in detail. One of our core values is that we huddle. So internally, our team of interdisciplinary professionals work together, collaborate, talk, game plan, strategize, and implement for the benefit of our clients. We huddle externally with professionals such as Dr. Dinkler and Dr. Rappel to, again, keep them in the loop on how their patients are doing, and essentially give feedback, guidance, and probe them as well for any additional resources that we may need to, again, ultimately help to the benefit of the client. So that's who you have here tonight, and the 4 walls that you are in the presence of. And this is not working, which is cool. We're going to go ahead and do this. Okay. So the goals of today's talk, we're going to go through a few things here. We're going to understand what atherosclerotic cardiovascular disease is. We're going to talk about why do we need to talk about this. We're going to understand and teach you guys how to improve your odds to mitigate or even potentially reverse some of the effects of this disease. We're going to talk about some of the nutrition recommendations that can help promote cardiovascular longevity. We're going to help you understand your cardiovascular fitness baseline. We're going to give you some training advice to promote cardiovascular longevity. And finally, we're going to look at the ability to affect our current predisposition to cardiovascular disease. So a very quick disclaimer before we begin any of this, okay? This presentation is solely meant for educational purposes only. There is going to be a lot of good data that you can take. We advise you, before you take any action, make any changes to your nutritional planning, any changes to your exercise routine or recovery routine or anything like that, that you consult your medical provider. We want to make sure that they're safe. Drastic changes can obviously have adverse results, and they're not right for everybody. So we advise you, take this for what it's worth. ask questions, but seek appropriate advice. Cardiovascular disease. Atherosclerotic cardiovascular disease. All right. It's a condition caused by buildup of plaque in your arteries. Okay. Everybody's kind of familiar with that and heard about that. Plaque is essentially made up of cholesterol, fat, calcium, and basically any other other substances that are kind of freestanding, free floating that are going essentially through our bloodstream, and they accumulate to form these hard calcifications on our arterial walls. Okay. This leads to a narrowing of the blood vessel. All right. And it reduces blood flow. There are underlying factors in our blood and compounding physical factors that play a role in this process, which we're going to learn more about. Okay. So we have an inherent risk here. All right. We hear very commonly, oh, I've got a family history of heart disease. And while genes are a predisposition, it's not a determinant of the disease. Yes, if you do have a family history of coronary artery disease, you are more at risk, but it doesn't necessarily mean that you're guaranteed to get the process of the disease. Okay. You are at a higher risk. All right. So there are other variables that are at play here. Epigenetic influences, all right, which is basically, the epigenetic influences affect gene expression. What are epigenetic influences? Well, essentially, it's just a signaling of information that we get from our diet, so the food that we eat, and other things such as exercise, right? These all are coded by our system, and then they have some sort of effect on our genome. Okay. We also see diet frequency and plant pattern. We're going to talk a little bit more about the benefits of a plant-forward diet, and then also certain feeding cycles. You guys I'm sure have heard of certain cycles such as intermittent fasting or fasting. We're going to talk a little bit more about some of those strategies that you can put into play as well too. Smoking. I think it's pretty straightforward. Probably not a good thing. Definitely not a good thing for any of us to be going through and doing. This needs no explanation beyond that. We'll talk about the influences of body weight, body mass, body composition specifically. We'll go into a little bit about hormonal influences, physical activity, and then lastly, your microbiome, which essentially is your gut health. All right, we've heard a lot about that. Okay. So ultimately, all this amounts to is that we're not going to give genes we're not going to give them any more power than they actually go through and really truly command or deserve over our current situation and potential situation. All right. So why is all of this important? Okay. Well, we have lifespan and your health span. Lifespan is pretty straightforward, right? It's a binary measure. Okay. It starts at the time that you're born and ends at the time that you die. Okay. We all know, though, that we've had some years where we've had really good years, right? Good decades, maybe, where we're healthy, young, active, vibrant. And we've had, maybe some years and some times where we're mired by disease or other issues that have kind of robbed us of the lifestyle that we ideally would want to go through and live. Okay. So our health span, the medical definition of a health span, is a period of time by which you are free of disability and disease. Okay. Our definition of health span is the ability to self-control and optimize functional performance physically, cognitively, and emotionally for the current decade that you're in. Okay. So it's ultimately just optimizing your lifestyle and your ability to do the things that you want to go through and do. All right. Some of the pretty interesting statistics specifically about coronary artery disease and cerebrovascular disease is that it is essentially the primary, it's the first leading cause of hemorrhagic stroke. Okay. So individuals that have CVD are at such a greater risk of developing a stroke, which again, individuals that, obviously have had a cerebrovascular accident and are now robbed of their ability to function, this is a pre-indicator for it, right? So we really, if you think about some of the disease processes that we want to ultimately avoid, finding a way to determine, the individual's predispositions to a cardiovascular disease is a very important source of information for us that we can start to alter the path toward. right. All right. So we're going to talk now about maintaining your cardiovascular health. Okay. So some of the things that we can do to improve your odds. Number one, don't smoke. Pretty straightforward. Okay. 2, get annual blood work done. All right. We'll talk about some of the factors that can be seen, and I'm sure these gentlemen can elaborate on some of the factors that, or some of the labs that are most pertinent, most important that you guys should be analyzed for individuals on an annual basis. Start the process of taking control of your care early on. The longer you wait, the more this stuff compounds like interest in a negative way, right? You've always heard it's harder to kind of like start getting the ball moving from, 0 than it is to maintain something that's already moving in a positive direction, right? It's inertia, an object in motion stays in motion. It's easier, right? So ultimately for us, the earlier that you can start the process, the more momentum you can build in a positive direction, which is going to have positive effects on outcomes. Ensure nutritional consciousness and consistency. Okay. Maximize and maintain lean muscle mass as you age. We'll explain why that's important. And then optimize your cardiovascular performance for your age. Okay. Just very interesting to see average lifetime risk factors at the age of 50 years old. Men are about 50%. There's a 50% risk that with the presence of a risk factor that they are likely to potentially develop coronary vascular disease. Okay. In the presence of 2 risk factors, which we'll talk about, that number skyrockets for both men and women, right? So, anytime, and these are all along the lines of considering risk factors, right? If you smoke, if your nutrition's off, if you're not exercising, these are all risk factors. Okay. Next. All right.
Okay. Hi, everybody. I'm Francine, I'm the nutritionist, and I wanted to talk about, this is the metabolic syndrome and insulin resistance are some terms that you may have heard of. Metabolic syndrome is pretty prevalent in America. It is not a disease. It is a pre-disease state. If left without attention to it, it can progress to disease. And what the reason I focus on this is because it is the underpinning of many of the modern adult diseases that we see: cardiovascular disease, cancer, neurodegenerative diseases. And what I think should be comforting to the people in the audience tonight is that these are reversible. And with diet and lifestyle. So many people come to me and say, I don't want to go on another medication. I want to, and I'm not against medication. Believe me, there are people I have walked to CVS to get their prescription filled. But this is there's a long on-ramp to some of these chronic adult diseases. And so we can start working on, when you get your blood work, and you should, have some literacy with this, fasting glucose. And by the way, some of these numbers are in the normal range, not necessarily healthy, but normal. So I don't like to see fasting glucose really even in the high 90s. I prefer to be in the 80s. Blood pressure, again, these are numbers that are 120/88 is where we prefer it to be. But if you start seeing 3 of these biomarkers that are out of range, triglycerides, a blood fat, that's on your lipid panel, fasting. These are fasting numbers, okay? Lab says less than 150 is normal for triglycerides. What would make triglycerides elevated? Well, if you were not fasting for the test, you would expect them to be a little bit higher, but it's a blood fat. People that have a lot of body fat will tend to have elevated triglycerides, but very sensitive to diet and to body weight. So that should also be encouraging. Productive cholesterol, the HDL cholesterol, should be greater than 50 for women and 40 for men. So if it's less than that, that could be one of those features of the metabolic syndrome. Again, 3 of those. And the one I stress a lot is the waist circumference, because you can see that when somebody walks into the office. And this is independent of weight, by the way. So you could have somebody who's in a normal BMI, but they have that body shape with the central obesity. And that is, to me, that's a red flag. And to me, that is a sign of insulin resistance, which is coming up in the next slide. So again, this is something we can work on, and we can see clinical results with even sometimes people that have maybe 20 pounds, 30 pounds to lose. With 5% of their body weight, you start to see clinical improvement. And that's another fact that I find encouraging that people can work on. Can go to the next slide. So what is insulin resistance? It is a state where the body is making insulin, but the body's not using it efficiently. And so on a fast, insulin is a postprandial hormone, but it also is a fat storage hormone. It tells the body to store fat. And where does it tell it? That's another one of those, that big waste that we see is often those people have elevated insulin. And so what we want is insulin sensitivity. We want the cells to clear glucose, and insulin is what helps. Insulin chases glucose into the cell. That's what it does. So the metabolic syndrome is associated with insulin resistance, and they're at risk for cardiovascular disease. Next slide.
All right. All right. So what else can we do to go through and improve your odds? So we kind of talked a little bit about getting annual lab work done. Okay. So medical testing obviously has advanced over the decades that we've been going through and doing this, as these gentlemen can go through and tell you too. What we typically see, or what is kind of getting a lot of ground, especially in social media, and what you'll see come out in the news and studies, are, specific lab panels and all this stuff. So a few of the common tests that, we will typically go through and see that are determinants of the development of coronary vascular disease are a few of labs that are kind of detailed in the Boston Heart Labs panel. So when I'll let these gentlemen talk a little bit more detail about these in a minute. But you have your apolipoprotein beta, sorry. You have your low density lipoprotein particles, and your very low density lipoproteins, which are basically just your bad cholesterol. Okay. You have your coronary calcium score. Okay. Essentially what that is it's a scan that can actually detect calcium buildups in the coronary arteries. All right, so these are predetermined markers and indicators that atherosclerosis is occurring. Okay. We also see some evidence behind biometric impedance for body composition. Essentially, this is a body composition test where an electrical signal is basically passed throughout the body. It travels at a different rate through lean skeletal muscle and body fat. And it's essentially a predictor of an individual's body makeup, how much fat they have, how much lean skeletal mass they have. The other weight that would contribute to an individual is obviously bone mass and water weight. Okay. So that is a marker. And then we also have a DEXA scan. And essentially what a DEXA scan is, it's a scan that analyzes bone mineral density for anybody that's going in and get checked out for osteopenia, osteoporosis. But what it can also go through and do is determine, again, this body composition breakdown. So it can also go through and parcel out how much lean mass versus fat mass an individual has. And why is that important? Francine kind of hit the nail on the head on the previous slide, right? Individuals that tend to have that high waist circumference or fat that kind of piles up around that midsection tend to be a little bit more insulin resistant individuals, putting them at higher risk for metabolic disease, diabetes, and ultimately, as we found, CVD. So we'll pause here for a very quick second. Dr. Dinkler, Dr. Rappel, do you guys want to comment anything on what we've kind of talked about so far, or anything specifically on labs or anything like that? Do you guys see?
Yeah. So there's a whole rabbit hole world of lipidology that people. I'm not a lipidologist. I'm a general cardiologist, but there's plenty of people that spend their life just focusing on lipids. And we've learned a huge amount about the lipid world over the last decades, and we're going to keep learning more and more. That's the nature of science and progress, is we're kind of figuring out which of these things are important, which of these things are markers, which of these things can we do anything about, which of these things, if we lower them, does it actually make things better? And it's an evolving learning process. I would say, to keep it simple, the thing I tend to focus on most, and the thing that people see me the most for as a primary prevention, is LDL. So LDL cholesterol. Atherosclerosis is predominantly an inflammatory disease, and LDL is predominantly, as we understand it, an inflammatory molecule that starts the process of atherosclerosis. So somebody comes to me with an LDL of 130 and they're, maybe 40s or 50s. LDLs, it's probably a modestly elevated, a little bit elevated, but do I do anything about it? Depends. Depends on some of these other things like family history and do they have diabetes? What's their blood sugar? What's their blood pressure? And often, as I'm trying to make decisions about what to do for patients, I'll send them for a calcium score. Calcium score has limitations. It's not a perfect test, but it's a helpful test. The reason that is if I have a premenopausal woman, sending them for a calcium score is probably not going to be very helpful because that process of calcification usually occurs later in life. And even so, younger men, premenopausal women, sometimes I'll get a calcium score, but I know ahead of time and I talk with them ahead of time about the limitations. Your calcium score of 0 isn't going to reassure me all that much if you have an LDL of 190, for example, is what I tell some of my patients who come to me a little earlier in life. But let's say somebody has an LDL 130 and a calcium score of 500. I care a lot about that person and how do I optimize their risk factors a little bit better. So LDL is kind of the main, thing that I focus on most with a lot of my patients. There's a whole other host of molecules that we do care about as cardiologists, but that's probably the take home. And then the calcium score, great test, use it all the time, but it has limitations, but it's very, very helpful in terms of kind of determining your individual risk, which I'm seeing a lot of this through the years.
So I agree with everything that Dr. Denkler has said. My approach is very much in line with that. Just to clarify, I agree wholeheartedly that when we look at people's blood work, for instance, because people have questions about blood work, just to let you know, in case you get confused, you want your LDL to be low because both begin with the letter L, and you want your HDL to be high because they both begin with the letter H. Easy way to remember. And yes, your LDL goal is going to depend on your profile. So the 21-year-old healthy adult who has an LDL of 130 or 140, I'm going to tell them, watch what you eat and go up. But you have the 40-year-old who has an LDL of 102, which doesn't sound so bad, but they had an angioplasty and a stent 2 years ago. That's not good. Their LDL should be 60. So everything has to be taken into consideration based on the patient. The next thing I would talk about is we talk about these sophisticated investigations and advanced lab tests. For me, in the general population of the primary care arena, the doctor that you all go to for your annual checkup, from my perspective, there are so many people out there who just need basic evaluations to get them on the right track, that doing the advanced testing really doesn't come into play except for a small percentage of people. So things like ApoB and doing the VLDL, they're really not of very much help, not for me, unless you have a very specific need. There are so many people who just need basic education on physical fitness, exercise, and basic nutrition. A lot of things that you'll read or hear about that we'll see on social media promoting things to make other people money, those aren't usually the best, and they're most often not sustainable. In terms of body composition, I wholeheartedly agree that people really ought to pay attention to the fact that, particularly in young women and older men, it is not hard to start losing lean body mass unless you do something on a regular basis to maintain it. If you take a look at men in their early 30s, they may lose 0.5% or 1% of their lean body mass in a year, but 0.5% is really not noticeable. But when they go from 32 to 35, the next drop will be 1%. I'm just throwing numbers out there as an approximation. You start adding those up, and each time the drop occurs, it's a bigger number. By the time you're 60 years old, you've lost a fair amount of your body mass, lean body mass. If your weight has remained the same over a long period of time, but your lean body mass has dropped, that means something else has gone up. And most likely, it's going to be body fat. The way to avoid that is to make sure that when you're doing some of your exercise, you're doing some exercise, including resistance training, not just cardio training. That's more of a deep dive on exercise education that Mark and his team can talk about. But the bottom line is, for me, there is enough information out there just to deal with the basics for the vast majority of the population to get people more in line with what they want to do from the basics without using fancy stuff. Coronary calcium scores. My wife is in her late 50s and is basically healthy. Her brother had bypass surgery at age 46. That's a really big risk. My wife does not have hypertension, diabetes, and she doesn't smoke, and she does physical activity 6 or 7 days a week. Her body weight is exactly in the right range, but her cholesterol is 300. Her LDL is 210, 205. Her doctor put her right on a statin. My wife said to me, do I need to take meds? I said, let me see. LDL, yep, you got to go on statins. Now, she says, what about if I change my diet? I said to her, it'll probably help a little bit. Your body is manufacturing this, and this is the genetic piece that Mark was referring to. There are ways that you can actually tell your genes to behave differently, which they're going to get into a little bit later. But for her, her LDL was so high, regardless of the fact that she only had one other risk factor, and that's family history, she has to be on a statin. And probably she'll have to be on a statin for a long time because that's not going to go away. So we had sent her for a coronary calcium score, which was probably a waste of time, because if she has plaque in her arteries, but the plaque is not calcified because she wasn't at the right age, you won't see it. So just because you have a coronary calcium score of 0, that means you don't have calcified plaque, but you can have plaque that's not calcified. So that can give you a false sense of security. The other piece of it is, and if you could imagine for a second, a hose. A hose has an exterior and an interior. When you do the coronary calcium score, you can't tell if the calcification is on the outside or on the inside. I had a patient who's a friend of mine, he's in his mid-60s. He has hypertension, he has hyperlipidemia, high cholesterol, he's pre-diabetic, and he has gout. And he's 300 pounds. However, 260 of those pounds are muscle because he used to be a weightlifter. But he's much too heavy. I sent him for a coronary calcium score. And by the way, for a guy who's 65 years old, a number that's under 250 or 300 is probably not terrible. He was 3,600. I called him at home at night and I said, hey, you got to go get a stress test. He said, I can't believe that. He did a nuclear stress test and he almost broke the machine, but he had nothing wrong with it. So how could that be? Because his calcifications are probably on the outside of the artery, not on the inside, which is much less relevant for him. Cardiologist said, come back if you get symptoms, otherwise go back to your primary care doctor. So a lot of these things have to be interpreted in a way that makes sense and are useful for the patient, and then giving to them an information in using language that's useful rather than getting really scientific. So I just thought I would throw those clarifications out.
Thank you. I was thinking both.
Yeah.
I'm learning stuff, which is a good thing. So that's great. Very important stuff, guys. Do you guys have any questions on anything up to this point? Yes, sir.
Well, what I don't understand is this. Why is it doctors wait till you get something and then they give you medicine for? Why don't they tell you how to avoid something before you get it? Like cholesterol or something like that, what caused it? They don't tell you this and that. You just put you on medicine. I mean, I followed. Then you got followed in health. I go to health seminars all the time, right? So I'm trying to think. It's just like there's a thing called micro pacemaker. I doubt the average person ever heard of micro pacemaker, right? And then you got the other pacemaker that stick out your chest. But then a lot of times people don't tell you about these different things. If you don't know someone that personally that you could talk to, you tell them what your situation is, they can explain it to you. A lot of times medical people don't explain things to you. That's when things get bad, then
Yeah, I think it's a really good question, right? And again, I think, and this is a fantastic point because and Dr. Rappel, this is probably right up your alley here on this. I mean, you guys have now heard Dr. Rappel elaborate on a few things, and even on his introduction, one of the main things that he said that he hones in on with every one of his patients is this educational piece, right? We have to understand, though, that not every practitioner in any portion of the medical field operates the same way, right? So, Dr. Pell, I mean, maybe you can elaborate like a little bit more, maybe talking, I want to be very careful with this, but inside the profession, most individuals are going to start by seeing their primary care physician first, most of the time, right? So on your end, what are some strategies that you've gone through and seen that's kind of taken a good precedent with your patients to kind of educate them and put them on the right path? And where do you think, and just kind of globalize it maybe to the profession as a whole, where maybe sometimes, practitioners may fall short?
So I can only speak for me and the colleagues that I'm familiar with. But when you have a patient population, I'll give you a really good example, and this will clarify it. I was asked to give a talk about cardiovascular disease to a group of engineers. These are people who know more math and more physics than I will ever know in my life. But the vocabulary that I use to describe things is not the same as when I was asked to give a talk to an audience of just ordinary citizens who are not engineers. What that means is when you talk to patients as a healthcare professional, you need to know who your audience is and speak in a language that's useful to that person. Otherwise, the words are meaningless. That's the first piece. Second piece is, I think it's important to identify what the patient's expectations are. After you explain what your job is as the doctor, what is it the patient is expecting? And are they willing to be collaborative? I don't believe in the old-fashioned paternalistic attitude of, I'm the doctor, you do what I tell you. How about, I'll tell you what I think is a really good idea. Let me know if you think you're willing to do that, and let's put our heads together and come up with a plan that makes sense for you. Because the plan that makes sense for you may not make sense for you. To address the question that you brought up, and I think that's very valid, is why don't the doctors do something before it gets there? Well, if today was your first visit in my office, I didn't know you before today, so I can only start with what I have. Once we get a baseline and we move on from there, we can address things as they come up. However, in the adult population, especially in the US, there has been a lot of nonsensical information that was provided throughout the decades that was inappropriate. TV commercials in the 1950s, beef, real food for real people. Wonder Bread helps build strong bodies in 12 ways.
Yeah.
1960s television, right? Well, we now know today that maybe Wonder Bread is not the best choice, and eating beef is not a sin or a total crime. And if in the right circumstances, it's not a terrible thing to include occasionally, but may not make sense to make it a staple of how you live your life. The second piece of it is, as people get to a certain age, 35, 40, even Mark's age and older, people get set into a certain set of beliefs in a certain set of ways. Change management and change resistance becomes a challenge, where a person will continue doing things the same way. Even if you give them information, they'll take it, digest it, and come back at the next visit and nothing has changed. Well, you've given them the information, you've given them a tool on how they can maybe make a change, but a lot of people don't get engaged with what they really want to do. And unfortunately, that's just a product of human nature. With all that being said, it's up to us to try to take our patient's emotional pulse and figure out, is this person really engaged? Or is this person just going to yes me to death, and for the next 5 years, nothing is going to change? Because if I keep on giving the same information and nothing is changing, I'm basically personifying Albert Einstein's definition of insanity, doing the same thing over and over again and expecting a different result.
Okay. I got a good one for you. I got a good one for you. Now, when I was growing up, right, watch television, you got Roy Rogers and all that stuff, the Marlboro Man on TV, right?
Sure.
Come up to
Okay.
Marlboro country.
Yeah, Marlboro country. He said if I had to do it over, I wouldn't smoke after he got cancer, right? Marlboro Man. Okay, well, my thing is this. When I was growing up, you didn't see cancer commercials on TV, right? You didn't, so you wouldn't know anything about it. Now all you see is like women live longer or something. You're gonna die of cancer or whatever, but you'll live longer. You take this medicine, right? So I mean, if cancer was out there all along, how come no one never spoke about it back in the old days?
Good question.
No commercials about it. Now all you see commercials about to take this for this cancer, take that for that cancer. Growing up, you never heard about cancer. People don't even talk about it. You don't know who got cancer.
If you take a look at how information has been spread in the last 50, 60 years in this country, the revolution and evolution of how information has been spread, forget about the internet, that revolutionized everything, but getting people to understand things at a very fundamental level. I mean, as a kid, rather than waiting until someone's middle age and they come down with some disease before you tell them, because that information just wasn't spread. It didn't sell. How long has tobacco been out there? Forever, right?
Forever, right?
The leading cause of preventable death in the United States, other than COVID, is smoking in adults. The leading risk factor for cardiovascular disease that's preventable is smoking. The leading preventable cause of cancer in the United States is smoking. The most common cancer in adults in the United States is lung cancer. And the most easily reversible, modifiable, preventable risk factor is smoking. What if we got the entire population not to smoke? 50 years from now, thoracic surgeons would be having to change specialties because they wouldn't get people with lung cancer. I mean, obviously they'd find something else to do. But the point is that this information that we now know is very difficult to manage, largely based on the fact that cigarettes have nicotine, and nicotine is an extremely addictive drug. Once you got somebody hooked on a substance, very hard to get them off. And the fact that it's legal and readily accessible everywhere makes it even worse. So you're right that the information, why wasn't it given before? Well, it really didn't sell, but now it's out there. And we now know that the cigarette manufacturers knew about diseases associated with it, but they basically paid people off to have that information hush hush. And that came out about 15 years ago in the courts and blah, blah, blah. So the big tobacco companies got a smack on the wrist. They paid a few $1 billion in a penalty and they continue selling. Less in the US, but if you go to Spain, Greece, Turkey, South America, their cigarette sales are more than they ever had. People will spend money.
Yeah. The one comment that I would make about, why would doctors just want to give you medicine and not talk to you about it? I think, certainly it depends. There's plenty of doctors, two of them here, who talk almost every visit. I spend probably about 5 to 10 minutes, probably more like 5, just based on limitations, but talking about lifestyle. What can you do to move more? What can you do to eat better? And a couple of other things. So we talk every visit with every patient about those fundamental things. But sometimes you need medicines. So they're again, once the horse is out of the barn and you've got the coronary calcium and you're coming to me, we'll talk about diet and exercise, but we're also going to have to talk about medications. So there's certain situations when, yes, there are things that you should do to prevent it. There's certain things where it gets to the point where you have to use medicines, or at least we should have a conversation about what that medicine would mean, a shared decision-making process about what the risk is of taking X, Y, and Z. But in conjunction with that, medicines are great, but there's other things that you can do on top of medications that are really going to help that health span that Mark was talking about earlier, which is really critical, because nobody wants to live to be 150 if they can't move, right? But we really want to make you live fuller, healthier, more vibrant lives.
What I want to know, if Korea disagree with me, like when you go see a doctor and you say you have cancer, and first thing doctors, or it could be something else. First thing a lot of doctors, first thing they want to do is operate. A lot of times they don't tell you got other options before you operate, right? It's like you get cancer, and then what? And then instead of operating, they can do a cryoablation where they can freeze the cancer And you don't have to open you up, but the doctor's not gonna tell you what the options you got.
That's why every patient should have an ongoing relationship with a primary care provider, where they may have gone to some specialist for evaluation and something didn't sound quite kosher. So now they go back to their primary and say, hey, listen, I went to such and such place and they told me this. What do you think? And that's where the trust and the bond between a patient and a primary is so important. If a patient doesn't have access to that on an ongoing basis, they're a little bit kind of lost. They don't really know who's going to be their guide. And that's really what one of the jobs of the primary care. There are a number of patients who I can tell you that have gone off to some of the subspecialists and they say, all right, doc, I'll let you know. They come to me and they say, hey, what do you think of what the specialist said? Sometimes I agree. Sometimes I say, let's get an opinion somewhere else in a different direction, because I think there might be some more information. But that's where the job is for the patient to A, advocate for themselves, sit up and say something, and talk to your primary care doc about being your advocate for you if you can't on your own.
I just want to dovetail off of that just very briefly, because I think, both of these gentlemen made some excellent points. The one thing that I'll go through and say is sometimes, and you have two expert level caring practitioners here who've made a career of really taking the time, energy, and efforts to enhance the benefit of their patients' lives. Some individuals just don't have a good enough network to get you over to the right person that can help you in that specific time need. Sometimes, yes, it's a change resistance, but sometimes that individual that you may be in front of may not know the right person who they need to get you to at that point. That could be a medical professional. It could be a fitness professional, right? It could be a nutritionist, right?
I just have to
Yeah.
dovetail onto your dovetail.
Please.
Also the insurance. And I strongly urge everyone in this room that has, modern healthcare insurance to advocate and challenge them too, because they are dictating our care for a lot of everything.
Yep.
So not to open that can go more,
Absolutely.
but we have to.
Are you done?
I am going.
So just a couple of comments as I'm listening to a lot of things now. To the gentleman on the end there, I forgot your.
Yep.
I'm sure over the last 5 years, you must have had 1,000 people tell you this. But in case you haven't, I'll be the first one to say it. If Anthony Fauci had an identical twin, you would be. If nobody has told you that, I would think certainly in the last 5 years, he must have had a zillion people. Well, is that Dr. Fauci? I mean, because you are virtually his identical twin. But I don't know if anybody's
He's gonna
mentioned.
show you the show side.
You know, but you definitely.
You've opened up Pandora's box.
No, and I mean that in a good way, not a bad way.
So I started following Tony Fauci
Yeah.
in the 1980s when I was in medical school, because unbeknownst to most of the
Yeah.
people in the world, he led the world through the epidemic that we dealt with of HIV when nobody had ever heard of it yet. And every week, the New England Journal of Medicine, which is kind of like the Bible for us, would come out with a new article about this discovery and that discovery of HIV. And the lead author, Anthony Fauci, National Institute of Health.
1981 was my name.
This is my daughter's graduation. That's my picture, and I just made a
Right.
collage for this.
Was I pretty close to the mark when I said.
Spot on.
But you haven't been told that 1,000 times over the years?
More than that.
I was gonna say, yeah, I was gonna say.
Unfortunately, some people didn't think it was very positive, but nevertheless, he led the world through Ebola. He led the world through what was going on with the difficulties with cholera after the floods in Haiti. And what do you mean he's a crook? He's a criminal? I say, listen, stop the nonsense. Listen to the guy. When I had a problem with the roof on my house, I called a roofer. I didn't call a plumber. He's an epidemiologist. He's a scientist. Since when did people who are in politics all of a sudden become experts? That's not the purpose of this discussion. But you brought it up.
Yeah.
If
I
you
only
have a
brought it up for
question-
that reason,
If you
not
have
for all
a
the other
question
factors.
about something, you have a question about science or about exercise science or fitness, he's the guy to ask.
Mhm.
If you have a question about, gee, how can I work to optimize my nutrition? this woman who's presenting or this young lady back there who present can also give you information about that. Ask the right person. If you don't know who to ask your PCP, your primary care doctor. Because that should be your real, the ringleader in your life. We think of it as a bicycle wheel where the patient and the primary care doctor are in a handshake at the hub, and the spokes are the rest of the healthcare system.
And I'll just take the analogy even one step further than what you're doing there. I'm type 2 diabetic, so I see a lot of different specialists, from an endocrinologist to a cardiologist. I probably see more doctors than all the people here combined, and I have since 2015. Doctors it's a lot like dating. It's not like, in my case, like having different girlfriends, right? And what happens is I'll say I've gone through since 2015, say maybe 4 or 5 different physical therapists, probably 6 or 7 cardiologists, maybe about 4 or 5 endocrinologists. So, it's just like the song from the Stylistics, do you break up to make up all that? And now finally I have a team, because I consider myself the CEO, and my team, I finally have an excellent team with Mark here, with my endocrinologist here, Marina Rosewater, with my Dr. Jennifer Taylor over at Griffith Hospital. It took a long time because, you're with them and you're doing this and that and the other thing, but I finally have a team that I could work with, but see, the system's broken, right? And there is no easy shortcut, what I'm saying? When you find the right one, that's like, I guess, the equivalent of your soulmate. You don't want to lose that person, what I'm saying? So the team I have right now, I don't see myself having to get rid of them or move on and find somebody, what I'm saying? And that took a long time. Just a few other quick things. I don't want to make this a whole matter of protracted discussion. When you talked about like Wonder Bread and other foods from the 1950s, 1960s, you got to remember something too. We were not crop dusted. We didn't have GMOs. Food was not made the same way that our parents and grandparents ate like they did today. If you drank a quart of soda, what they call the soda pop back in the day, right? That only had a fraction of the sugar and all the bad stuff that you have today. So keep in mind that food and drinks and everything that were sold to us and that we imbibed decades ago is not the same, doesn't have the same degree of toxicity and sugar and so on and so forth. Okay, so that's one aspect. The other aspect, and you kind of touched on it, but I would say follow the money, right? They were giving out cigarette rations to our Vietnam vets all the way up to the 70s. Cigarette rations from World War I, World War II. It was just given to the troops. Now, because you touched on it and you said, well, why is it that it's so? When people didn't know about it, lots of money in it. Okay, if you're well and you're healthy, there's no money. Okay. For big pharma and big tech to, what I'm saying, to take care of you, right? But if you're sick all the time, now we got ourselves, he's got to see this specialist, that specialist, this, that. So there's that end of it too. And I don't want to make it all about that because we don't want to go into politics, but the bottom line is this: you follow the money. Anything you see that's happening around you, you just follow the money. Why is it the way it is? It's very simple, okay? There's no money in people that are healthy. The messaging throughout up until the late 70s, well, until the 1980s, when you had 24/7 cable, right? Because news kept going 24 hours a day. Well, no, actually it shut off at 10, 11 o'clock, and it came back on 5, 6 o'clock in the morning. But CNN, 1980, first time it was a 24-hour network. Then all the other networks followed. And the messaging was different starting in the 80s. And you know this as well as I do. When eating and exercise is not enough, take this drug, take this, take that. So for 4 decades, we told a whole generation, oh, you have a problem? No. When eating and exercise is not enough, take this drug, take this. And then you know what happens? They cover their butt. They create the problem. And then 6 months, a year, 2 years later, oh, we have this class action lawsuit going because you took this experimental drug that we were telling you about for 4 or 5 years. They create the narrative that you have to take something in addition to exercise. Then they propagate it by saying, oh, we have a class action lawsuit. Jump on board. And they keep doing this, and they've been doing this for decades. So to your point, without going into a whole diatribe, right? Yes, there are good people like you out there. But you know, it's a lot like the news on TV. 90% BS, 10% the truth, but you need a shovel the size of California, no pun intended, to find the truth. So it's a lot of trial and error. And when you find the right people, you don't want to ever get rid of them. You don't want to ever get rid of them. So it's a sad reality, but that's unfortunately the way things are, you know, just saying.
Thank you, Mike.
This might take.
Yeah, thank you, Mike. Thank you
Yeah.
for sharing that. And gentlemen, thank you guys for your points and the questions. All right, so we're running a little bit behind on time here. So what we're gonna do, we're gonna table any other questions just for a few minutes at the end here. Francine and I are gonna kind of give you the meat and potatoes. We don't want to skimp over anything because we really have some good material for you guys here. So Francine, I'm gonna let you take the lead here on some of the nutritional tips.
Okay.
Just let me know. I'll take it from there.
Okay. And I did see some questions in the chat bar, so when I can tie them into the slides, I will, and because they were very good questions. We hear a lot of information and lately about diet, sometimes conflicting information about, are carbs bad? What about fat? I have people that tell me they're afraid to eat blueberries because isn't there sugar in blueberries? And what about eggs? My cholesterol is high, so they avoid eggs. So what happens if you cut out that egg? Maybe you're eating a sugary cereal, and that is just as detrimental to your health. The egg, depending on how you eat the egg, is a very good food. So a lot of dietary advice is very personal, and people tend to be very habitual. And so my approach is that I like to start with where somebody's baseline is. What's your current diet like? And then we improve from there. Some people come to see me and they're, which slide are we on? Can we go back to the Mediterranean diet?
Oh, I had it there. Okay. Do you see that there, Francine? Yeah, Francine.
Can we go back to the Mediterranean diet?
Yeah, I have it on mine. Are you seeing it on yours?
Oh,
Is it lagged?
no. Okay. Oh, as long as it's there, that's fine. I'm back to improving my odds and the testing. So, all right. So the Mediterranean diet, I know it by heart. I think it is the most, it's an enjoyable diet. It's associated with good health. There we go. And the regions that one of the doctors discussed before, Spain, France, Greece, Italy, even though there's higher amounts of smoking, they tend to have not just long lifespan, but long health span as well. And the diet is very enjoyable. I believe the dietary pattern is more important than individual foods. So sometimes people will come in and there's always a superfood. There's the food of the moment, the trendy food. It was kale, then it was quinoa. People come in sometimes and they confess that they don't like kale. And I'll say, well, do you like Swiss chard or spinach or escarole? Yeah, I love those. Okay, fine. So you don't have to eat the kale. There's a lot of guilt around food. So I usually ask for a food diary if they bring it in, that's great. Now people have all these exographs with their phones and they bring people up their food, but sometimes I think small permit better than just a whole redo, because it's going to do that. It's not sustainable. So I'll often ask about beverages. If somebody's drinking sugar sweetened beverages, maybe we just start there. We can improve that. Maybe it's the fats in the diet. Maybe we need an oil change. If somebody's eating a lot of unhealthy fats or food preparation with a lot of frying of food, that can make a very big impact. And I like those early wins because you can point to some clinical improvement in many cases. Small changes can make a huge difference. And that keeps them sort of, okay, I can do this. And now let's start with, maybe you're having a bagel every morning for breakfast, and maybe we can improve that bagel, but you're not going to go from a bagel to a vegetable omelet in one go. Usually it's just not human nature. So we get them to go to, maybe we can move them from a bagel to a half a bagel, and then the half with some protein and some fiber, and then maybe to an English muffin. And then move over to maybe they're doing oatmeal with fruit and nuts. And so that's really the best way to get people to make changes. The Mediterranean diet is a plant-forward diet. It doesn't have to be vegetarian, but it is plant-based and it's freshly prepared food, fish. The protein is usually not the center plate. There's lots of beans in this diet, garlic and onions, which are very helpful. They promote health. They're not just there for flavor. They lower inflammation. Somebody asked about C-reactive protein in the chat before. That is a measure of inflammation. And it's a useful number, especially when we track it over time. So we like to see that nice and low. That's one of the predictors of taken together with your lipids and your blood sugar and your body fat and your blood pressure. It's all really it's a pattern that we're looking at. A lot of vegetables will definitely improve your inflammation. Fish is very anti-inflammatory. Fried foods, pro-inflammatory. Fast food, very pro-inflammatory. So this is usually where we start, and we can go to the next slide. And so as somebody mentioned about muscle mass before, one of the doctors. So as we get older, people, especially over 65, require more protein just to maintain their muscle mass as they get older. Postmenopausal women, you need to change as you go through the stages of your life cycle. And if you tune into your hunger, you might notice if you're an intuitive eater that even your metabolism as it changes, that we require less food, but not less nutrients. So that's the rub with getting older, is that we want to make sure we're eating nutrient dense food. So I prefer the omega-3 fats. So that's the fatty fishes. I like these other foods like scallops, mussels, clams, those bivalve mussels and clams and oysters should be in there, are highly nutrient dense, very high in zinc, a very underrated micronutrient, trace mineral. Poultry, very high in taurine, which is very cardioprotective. I mentioned beef, not processed meat. The cold cuts have a lot of sodium in them. The biggest sources of sodium in the diet tend to be processed food, cold cuts. Cheese has a lot of sodium. So it's not so much the salt from the salt shaker that people need to be concerned about. But it is definitely the processed foods that tend to have a lot of sodium. I recommend for eggs, hard-boiled eggs, scrambled eggs with vegetables, great start. They sate you for a long time. You can really feel full for a long time, coupled with some fiber. I like protein fiber together, nuts and seeds if you're not allergic. And if you have functional teeth, right? Some of the people I see on lower incomes have failing teeth or missing teeth. That's very relevant for my diet recommendations. Extra virgin olive oil is a very good oil to use. It's good to have a couple of different kinds of oils, coconut oil, avocado oil as well. We can go to the next slide. We get a lot of mixed messages about carbohydrates. So the ones to limit are the refined carbohydrates, the ones that the body can turn anything into glucose. What you want is something that has a slower burn, something that is a little bit more complex for the body to break down. So legumes, whole grains, they're also very good for for blood vessels, and they're high in fiber. So what you want to limit is the sugar sweetened beverages, the high fructose corn syrup. If you look at the ingredients on a label, what I look for is added sugar. You don't want a lot of added sugar, but sugar, if you look at yogurt, for instance, you're going to see sugar in the label, but it's lactose, right? So anything that ends with an OSE is a sugar. Lactose is milk sugar, glucose is blood sugar, fructose is fruit sugar. So not all sugars are bad. So you don't have to be afraid about eating fruit. I would say better to have more vegetables than fruit. But if you're a person who doesn't like vegetables, then you want to eat more fruit. Or if you don't like fruit, then you eat more vegetables. But there's always a way to work with somebody's dietary habits. Some of them more glycemic. I know people that are afraid to eat bananas, afraid to eat pineapple. I tell them eat those after physical activity. They will replace the glycogen in your muscle and tend to not raise blood sugar. And also, if you eat them with protein, you're going to slow the release of glucose into your bloodstream. So let's move on to the next slide. Coffee, that's another one that people, it has sort of gotten a bad reputation, but we have found that coffee actually helps improve insulin sensitivity that we talked about earlier on in conversation. It's what people put in the coffee that is often not such a good thing. The fake creamers, 4 sugars, I would avoid that. But my recommendation is 2 before 2 if you're a coffee drinker. So that's something that people usually stay away from coffee as soon as they get diagnosed. I work with many cancer patients. As soon as they get diagnosed, they give up coffee and they start drinking green drinks. And I don't know why they do that. So sometimes I have to give people permission to do things that they really want to do, that give them joy, right? Never have anyone take away your joy. Next slide. So I think this is a good rule of thumb, is 2/3 plant, 1/3 protein. If you are, if not a vegetarian, if you are a vegetarian, then you want to definitely make sure there's enough protein. And it's not hard to get protein from plant sources. It's just not as concentrated as the eggs, dairy, meat, and poultry. Those tend to be higher concentrated proteins, but mix them up too. I always say, try to go for 2 different families and 2 different colors, right? On your plate, and rotate with the season. Right now, it doesn't get any better than right now, right? The summer produce is beautiful to look at. It tastes great. We have farmers markets everywhere you turn. So take advantage, speak to the farmers, find out what's, what they're growing. I just had sugar snap peas today. They were so good. This is really a wonderful time for the lettuces, for the arugula. As we move into the summer, the tomatoes, the eggplant, the zucchini. So that's my advice on the ratio and the diet. Next slide.
All right. Thank you, Francine. All
Thank
right, so
you.
we're gonna, yes,
Yeah.
sure, absolutely.
She didn't mention milk, cheese, yogurts. How about these things?
Francine, did you hear that about question about mayo, yogurt? Like, where do they kind of fall into the?
So yogurt is yogurt is a good dairy if you can tolerate it. There are some people many people lately in the last, I would say 5 years, are trying to quit dairy. And I always tell them there's a very big difference between ice cream, cheese, and yogurt. So yogurt has a different amino acid mix and tends to be better tolerated for even some people who are, now if you are demonstrated allergic to dairy, you have to eliminate it. But if you're sensitive to cheese, you might be okay with yogurt, and it is a very nice protein option to have. Mayonnaise has the same as calories as olive oil and butter. So fats tend to be highly caloric, but they also fill you up. So don't be so afraid to use them. Just use them the way, just remember, my mother, I'm Sicilian heritage, and my mother would pour on the olive oil. It's healthy, right? And I'd say, yeah, but you want to use it sparingly. But if you eliminate the fat, and if you notice a lot of products in the grocery store, when they are low fat, they add sugar and sodium because fat gives flavor. So sometimes in our attempt to keep with the trends, we are not doing our bodies a favor. So do use the fat. And when I write up a personal diet plan for somebody, I look at their, I usually have some clinical information, a referral from a physician. Our goal is to get their LDL down. Our goal is to get their A1C at a certain point. Sometimes they may be a candidate for surgery, and their doctor wants them to lose like even 5% of their body weight to get them in best pre-op. I call it prehab shape, right? So based on those recommendations, we'll come up with a diet, and I will write down for each food category. I don't do calories. I know what the calories are, but I'd rather do this number of servings of protein, this number of servings of dairy, if dairy, legumes. People in America are a little bit, they don't understand beans, right? They give me gas. Do I have to soak them? So there's a lot of mystery around legumes, but it is a big part of the Mediterranean diet. And we don't want to separate out what is it about this diet that is so healthful, but it's just the combination of the way it all comes together. It's the fats, it's the tomatoes, it's the garlic. Maybe it's sitting down with your family and enjoying a meal together, right? And that's part of it too. Not eating at night. That's why I talk about it. Give yourself, you don't have to do the intermittent fasting, but nobody should be eating at midnight. And you would not believe how many people do. I hear this constantly from people, then especially people that are very large. It's not, are you eating? It's what are you eating at midnight? And they always spill. They'll always tell me, how did you know? And so if you cut, so keeping your sun up to sundown is a pretty good window, right? If you think about our ancestors, they were not eating at 1 o'clock in the morning, right? They were sleeping early to bed. So yeah, so mayonnaise is a fat, but it's, again, you don't want to go smothering it on your bread. You can use it just to add, sometimes just the texture, the flavor. But yes, I'm fine with that. Avocado is another, I would consider that a fat as well. Okay, Mark, it's your turn.
Thank you, Francine. All right, so now we're going to talk about some fitness baseline measures that we can go through and see and use as viable outcomes as, again, predictors in an individual's predisposition to coronary vascular disease, right? So there's a lot of evidence and research out there on looking at different patterns in strength profiles, okay? So there are correlations to the lean mass scores that we saw in the DEXA scans that we kind of talked about earlier, in terms of the determinant of lean muscle mass to an individual's 1 repetition max strength, okay? Obviously, 1 repetition max strength, most individuals don't have the capacity or the ability to go through and really truly nor do they really care to go through and calculate that out. But there is a link, obviously, between to an individual that does have more lean muscle mass to their ability to have look at it as like an absolute strength output. Like individuals that have more muscle, they're stronger, right? Pretty straightforward, okay? Muscle endurance testing, right, has a similar effect on body composition, okay? The two, I think, predominant factors when you look at an individual's overall health across just any scheme or any spectrum is absolute strength and aerobic capacity, right? So kind of like points 1 and 2 here on these on the slide here, okay? So ultimately, while it's great to have muscle power, which we talk about in the quick twitch muscle test, right? Muscle power is good. Obviously, bigger muscles equal more powerful muscles potentially, okay? It all ultimately comes back down to absolute strength and aerobic capacity. Grip strength is a very interesting measure that we see here. There's actually a lot of evidence that shows a decline in grip strength and an individual's mortality rate, which is very interesting. So individuals that exhibit a weaker grip strength comparatively to their age appropriate norms have a lower mortality rate. So it's very interesting to kind of see that. So do a lot of farmers carries and walks and hold on to things that are heavy. Okay. So what tests do we kind of go through and see that can be used to kind of measure some cardiovascular fitness baseline? Well, we have different aerobic endurance tests. The most common one that you kind of see in literature would be a VO2 max test. We're all not elite level endurance athletes, so we're not strapping on masks and hopping on a Monarch bike and trying to do maximal output. But simple stress tests, that we can go through and do. Bulky test on a treadmill is a fantastic test to go through and supplement. And you have a lot of these sub-maximal predictive tests that will give you a very good baseline on where you're at from an aerobic capacity standpoint. Okay, we have anaerobic tests, which are kind of peak cardiac recovery. All right, going up explosively, and how does the individual essentially recover? This measure heart rate recovery. Is essentially, they usually measure it in a 1-minute interval. So the goal is that you do an activity, you will raise your heart rate to a certain point to a near, a near max level. And then in 1 minute, how many beats does your heart rate drop, right? So for instance, if I take my heart rate up to 160 and in 1 minute, my heart rate recovers to 130, where do I stand on that spectrum, right? Healthy individuals generally in a minute will drop about 40 beats per minute from where their maximal endpoint was. So if it was 160, in a minute, you'd see them usually get down to 120 when they're at absolute rest, okay? VO2 max, we kind of talked about in aerobic endurance testing. Resting heart rate, okay? This is something that every one of us can measure every day, right? Upon waking up. And we'll talk about wearable technology in a quick second. But essentially at a baseline, there's a very wide range that we go through and see from what a resting heart rate is considered norm. I believe it's still between 60 and 100 beats per minute, right? At a baseline. Okay. Interestingly enough, if you dive into some of the studies that kind of look at the autonomic nervous system, if even at a baseline measure, if your heart rate is anywhere above 60 beats per minute, your system is in a little bit more of a sympathetic fight or flight state. All right. So we really want this to get as low as it can go within reason. Obviously, if you have some degree of disease or pathology that's causing your heart rate to get really low, that's probably not a good thing. We want to watch out for that. So I want to make sure I put that as a disclaimer. But if you really look at some of, elite endurance athletes, marathon runners, they have heart rates that are in the 30s. Lance Armstrong, 32, 36 beats per minute, something like that. That was absolutely crazy, right? But that is an elite conditioned individual, right? So for us striving for here, the kind of general gold standard is as low as generally better. Okay. Heart rate variability. This essentially is when we're looking at, everybody has kind of seen the QRS heartbeat waves that we go through and see when you're hooked up to an EKG or something like that, right? Essentially, it's the kind of the peaks, the R intervals, right? The top point of the thing that jumps up, right? So essentially what that is, this is the reason why this is important. This is kind of like one of the ultimate indicators of an individual's fitness and health baseline, okay? Typically, we should have variability in how many beats our heart basically exhibits on a minute to minute basis, right? So where resting heart rate is an average, I average 60 beat per minute. 1 minute, it may be 56. The next minute, it may be 62, right? So there is variability on how many times our heart actually pumps out blood. More conditioned individuals will have more variability in their output at a baseline than under-conditioned individuals. So just kind of take that for what it's worth, right? And then blood pressure, right? Something that we take all the time. Obviously, we kind of had the blood pressure statistics earlier on. You're higher, your blood pressure, generally not a good sign, okay? So really talking about how do we measure all that stuff, and should we measure that stuff, right? Who here has kind of used some sort of measurable data point at some point in time, whether it's like an Apple Watch or Fitbit were the first thing that kind of went through out of start. These are all great things to go through and use, and they give you data, right? The hard part is that who's interpreting the data, okay? This is where I would probably advise you guys that if you are going to use this stuff, which I'm all for, have somebody like your physician, your primary care physician, interpret the information for you, right? Again, individuals like myself, I've educated myself on some things. So again, I will vouch for the use of these informational devices when I make changes to my diet, when I make changes to my training habits, right? I can see what the outcomes are doing. I know when I have recovered. I know when I'm doing too much, or maybe I, shouldn't have had that alcoholic beverage, or I shouldn't have eaten at midnight, as Francine said, right? I don't. I'm usually in bed by 9 o'clock because I have 3 young kids that exhaust me. So, but when I stay up till like 9:45 and I'm exhausted, this information tells me. So it lets me know, right? So don't get too caught up on it. But again, it's just a simple way that you can start to accumulate data, but then have somebody interpret for you if you don't know about it. All right, so just some general weekly fitness tips. So a couple of really disclaimers before we go into this, right? Exercise doesn't have to be going to the gym, lifting weights, hopping on the treadmill in kind of like a farm of people, right, that are just kind of herded through like cattle. There are many forms of exercise: hiking, climbing, yoga, tai chi, Pilates, resistance training. There's a myriad of different things. Raking leaves, shoveling snow, right? Absolutely. That's not for everybody, right? You gotta be careful with that, right? But ultimately, it could be anything that you do, right? And really, it's just going to be a measure of just, increasing intensity that's on stress that's on the system in a positive way. So these are just kind of general tips on what we should shoot for on a weekly basis. Okay. 150 minutes, so 2.5 hours, if you go through and look at it, of total zone 2 aerobic exercise per week. All right, what's zone 2? If you break down percentages of maximal heart rate into zones, okay? Maximal heart rate is 100%. You don't go beyond that or you die, okay? Zone 1 is roughly 50 to 60% of your maximal heart rate. Zone 2 is 60 to 70%, okay? So staying somewhere in the 60 to 70% range. And the way that you find that out, very simply, predict or sub-predict your sub-maximal heart rate, okay, or your maximal heart rate, and then just take 60 to 70% of that and stay in that range, okay? So again, forms of this aerobic activity: cycling, walking, hiking, rucking, something that you're doing for a sustained duration of time, okay? 3 days a week, you want to do some sort of strength training, okay? Some sort of resistance training that is going to work major muscle groups, right? That's going to create some degree of stress on skeletal tissue that's going to create an adaptation, right? Get you stronger, okay? A third of those days, so one of the 3 days, you should really focus. Evidence shows that really focusing on a strong eccentric or negative training program. So think about it like if I was going down into a squat, me going down into the squat is the eccentric. I'm controlling myself down. If I do that style of programming and focus on eccentric work 1 day of the week, helps to boost lean muscle. That's actually the eccentric contraction is actually the hardest contraction for our skeletal structure or our musculoskeletal structure to withstand. So it helps you build the most, it has the greatest outcomes on building the most lean mass, okay? 1 day of high intensity interval training. Okay, so you guys have probably heard of interval-based training potentially. So essentially what it is, it's kind of circuit style workouts done with little to no rest time, okay? And essentially what we're trying to do is get spikes in heart rate, right, and intensity. So generally these are not, contrary to strength training workouts, these are workouts that are kind of done at lower intensity loads, lower resistance, but they're done at a faster pace. They're done with quicker, more explosive movements, and they're done with the emphasis on trying to increase heart rate, right? And then come back down as quickly as we can. Okay. So doing that 1 day a week has a lot of benefits. All right. And then from there, we have 1 to 2 weeks of doing about 20 minutes of kind of peak heart rate training. So this is intervals of high heart rate exertion for 30 seconds to about 4 minutes. So these are more kind of like power intervals. And this does kind of tie into some of the aerobic activity that you can kind of go through and see. So you'll hear a lot about cardiac power intervals where you can so this seems like a lot, right? This seems like 150 minutes of this plus 3 days of that, plus then all this stuff, right? You're working out all week, right? But you got to remember that, as human beings, our genome are hunter-gatherers, right? So it's only since our modern technical society that in the Industrial Revolution, since we've really been sitting down and kind of confined to this lifestyle that we're currently living today.
Mark, would you
Yes.
say, excuse me, that some of these exercises, because a person looks at this who's not a gym rat, a person looks at this and says, gee, this looks overwhelming to me. This looks like it's too much. How could I do all this? Well, if you actually look at it, number 1 and number 4 have overlap. Okay. And when you're doing your strength training, you can do easily incorporating in negatives, as Mark was saying, on any one of those days. And when you're doing your cardio, when it says high intensity interval training, that may overlap with the 150 minutes also. So they're not mutually exclusive of each other. They can be overlapping. So you don't have to add them all up.
Correct. Yeah. And that's a great point. I mean, the thought process is, like we said, if you were to do these all independent of each other, you'd never go to work. You'd be working out all week. There is overlap. So understanding that there is overlap is the kind of important piece of the puzzle here. But also the other important part is to understand variance of training. Far too many people go to the gym and they just do cardio. They don't do any resistance training. They just lift weights. They're not doing anything from adding peak heart rate training or high intensity interval training into the mix. So they're doing one or the other. They're not combining things. So variance, I think, is the biggest key there. Okay. So you're training, you're working hard, you're working out, you're sweating, you're putting time and effort in. You have to recover from that. Okay. So from there, you also can't work hard and you know, just continue to think that I'm just going to go and plow through walls every single day and just train. That's a very bad way of going through and do it. Remember, exercise is a stressor. Okay. We want it to be a positive or a use stressor, not a distressor. So can we over exercise? Can we overdo things? We absolutely can. Okay. So an important part of what we see from the exercise standpoint is not just exercising, but being able to recover from exercise. And there are a myriad of different things that blend into this here as well. Okay. So research on this side, remember, what are we talking about? We're talking about reducing the risk of cardiovascular disease. Okay. 2 to 3 days a week of the following have been shown to have positive outcomes and effects on reducing an individual's risk of developing CVD. Okay. Infrared sauna. Okay. Or just kind of regular sauna as well, too, that you've gone through and seen. So, or like a wet sauna. Studies show that if you're using infrared sauna, show that a 12 to 20% risk of mortality, decrease in risk of mortality in individuals over the age of 50 who use infrared red light sauna 2 to 3 times a week. Okay. Regular sauna, a lot of these studies have been done in Scandinavian countries, because this is where a lot of the sauna portions of this, like traditional sauna, had origins begun. Using 15 minutes, 3 days a week at 140 to 180 degrees of temperature has also been shown to significantly reduce the risk of CVD. Cold exposure therapy, everybody's favorite. Yeah, right. Jumping in a ice bath, right? Okay, not my favorite, but it's amazing, right? Doing 2 to 5 minutes, 3 days a week, okay, can improve blood circulation, metabolic effects. Ultimately, what this is an anti-inflammatory agent, essentially, right? It's creating an anti-inflammatory environment in your system, okay? So if you really look, you know, if you look at the baseline, you'll see kind of like studies, cold exposure therapy, you want to try to aim for about 11 minutes on a weekly basis, cumulative. That is going to kind of get you to that sweet spot where you need to be to kind of get these changes here. Okay. One of the times that you implement some of these things should be used for some contrast therapy, where you go from hot to cold back to hot. Okay. So at least 1 day a week, you're doing something where you're in a hot shower and you go turn it to a cold shower for a few minutes, or jump into a cold tub and then hop back into a hot shower or sauna or something like that. Most of the evidence behind this are kind of looking at using sauna and you know, kind of like cold submersion therapy up to the neck. There's not a lot of evidence right now on like using like cold showers, just because there's a high degree of variance. But essentially, the important thing to know is that you can utilize some of these agents to have some sort of physiological effect on the system, and then using them in unison with this contrast therapy 1 day a week is a positive thing as well. Okay. All right. So this is just kind of like just a baseline, like, hey, like if we're going to kind of balance the information that science is giving us and kind of like what like a weekly or a routine may kind of go through and look at, right? So a routine maybe on a recovery day is, you do a 10-minute full body warm up, you do a 20-minute kind of resistance circuit activity, 30 minutes of cycling, and then you finish it off with 15 minutes in a sauna or do some sort of cold contrast therapy. Okay. So again, you're seeing here, we talked about that 150 or the 150 minutes, right? That we had kind of talked about, you know, now you're getting your hour worth of work and your recovery kind of all in a similar session. Right? This is just an example more than anything else. Okay. So how about our best recovery method, right? Yeah. Sleep. Okay. Who here doesn't get enough sleep? I've got 3 young kids, so I'm going to raise my hand for that. Yeah. So, you know, on average, right, most humans, especially in this country, are probably not equating our general guidelines, which is about 7.5 to 8 hours of good quality sleep on a nightly basis. Okay. Studies have shown that if you're getting sleep in the 6 to 9 hour range per night, drastically reduce the risk of developing a heart attack. Okay. So these are our general recommendations that we want. There are more general recommendations. There's not one specific recommendation because each of us as individuals, it's different, right? We all live different lifestyles. We all have different stressors. We all have different habits, right? So it is different, but this seems to be kind of the sweet spot here. So if we're not getting that, what do the effects of poor sleep have on us? Well, we're seeing elevated insulin levels, okay? We're seeing, which basically insulin levels go up, there goes your type 2 diabetes. That's going to, to potentially go through and spike. So that's number one. We're seeing an increased risk of hypertension, CVD, coronary artery disease, and obesity. That stuff all goes up. Coronary artery disease and obesity increased by 26 and I think 38% respectively in individuals that were getting less than 6 hours of sleep on a nightly basis. Okay. And right here, less than 6 hours of sleep on average, studies have shown increased risk of heart attack by over 20%. All right. So again, the important thing to kind of understand is that there are changes in your system. Our bodies need sleep. When we are sleeping, there is there's cortisol that acts on our system. You guys have all heard about cortisol, which essentially is it's a hormone that's released by our adrenal glands. Okay. And essentially, if we are hitting less than this range, that is going to spike it. It's going to spike it up higher. And that could potentially be one of the reasons from a hormonal level that we're seeing these types of changes that are occurring in individuals that aren't getting as much sleep. All right. So some recommendations to improve sleep quality. Okay. Don't drink alcohol. Period. That's hard for a lot of us. Yeah. Okay. It is tough. But again, alcohol, the reason why we want to try to generally avoid that is that while alcohol does initially kind of act as like a system suppressant, and it does kind of initially kind of like increase our need for sleep pressure, in the middle of the night, it's still acting and your system has to metabolize that. So it does affect your body's ability to get into deeper portions of their sleep cycle. Okay. So it will mess with your deep sleep, which is really your recovery state. Okay. So just stay away from it. If you have to have a drink, do one drink, do it before 6 p.m.
Wine.
Okay.
Glass of wine.
Alcohol, right?
Below 5-6 ounces.
So, I mean,
Moderation.
ultimately, here's the other hard part with that, right? Is that everybody metabolizes things at different rates,
Gotcha.
right? So there could be individuals that don't have any issue at all having a glass of wine with a 7 p.m. dinner and go to bed at midnight, right? But individuals that go to bed at 9 o'clock, and I'll just speak for myself. If I have a drink after 3 p.m., I go to bed at 9 o'clock, I'm waking up and, my heart rate variability, my resting heart rate literally skyrocket 10 beats per minute higher than it normally goes. Right. Again, am I more sensitive to alcohol than I don't know. These are things that we don't know. All I know is that I see what I have. Right. So ultimately, if it's alcohol, you want to just it should be sparse. You just need to be careful with it. Okay. So we just know the effects of it, and we know the effects in terms of how it does negatively affect our ability to get into deeper regenerative sleep. Okay. All right. Reduce caffeine intake. Okay. Francine kind of talked about her rule, right? The 2 before 2. Okay. So 2 cups of coffee before 2 p.m. Right. The thing to remember about caffeine is that it's got a shelf life, or a half-life, I should say. So it basically takes you about 12 hours or so to metabolize it. So think about it. If you have a cup of coffee at 9 o'clock, by, essentially 3 p.m., there's a half a cup of coffee, left in your system, and it's not really fully metabolized out until 9 p.m. So just think about that as you kind of think about when you're taking your last espresso shot for the day. Okay. Exercise, super important. That helps drive sleep pressure. Try not to do it too close to bedtime. Okay. Abstain from any electronics about 2 hours before sleep. Okay. Blue light, right? We've kind of heard some of the negative effects of that. Okay. And you want to limit your exposure to any stressful stimuli, such as doing any work, checking any work emails, God forbid, checking any social media about an hour before bedtime, right? The last thing you want to do is start to increase anxiety levels, which is going to help, which is not going to help your mind turn off and get you and really drive this sleep pressure, which is going to get you to sleep. Okay. You can take a sauna, hot bath, shower. You want to darken the room completely. All right. So if you have room door, you want it basically so you can't see in front of you. Okay. So you may, if you don't have room darkeners or room shade darkeners, you may want to use eye covers, eye shades, something along those lines as well too. Okay. And lower the room temperature. Studies kind of show like 65-ish degrees kind of seems to be the hot spot where you want to be, the sweet spot on where you want to be in terms of just kind of allowing your system to down regulate and relax. Okay.
Mark,
Okay.
one
Yeah.
question from Zoom we had
Yes.
about drinking water before bed.
Yeah. So excellent point, right? Bad idea. Bad idea. Right. I think that's I think it's pertinent to the individual, right? You definitely do not want to, as you age, right? Especially males, as we have some of our issues with prostates, right? You do need to be careful about it. General rule of thumb that I typically would kind of like engage in my clients with when I'm kind of, if that seems to be the problem, right? Drinking, hydrating before bed is kind of stopping, let's say you're going to go to bed, about 2 or 3 hours before bedtime, you're done taking in like full, drinks, like a full 8-ounce glass of water. You can sip periodically if you feel like you have the need to go through and do it. But I'd probably, just like you would, stop eating about 2 or 3 hours before bed. That would probably be a good guideline as well for that, right? And that's just going to reduce urinary frequency that you may have, at night. So yeah. Okay.
Quick question. I'm sorry.
Let's go through, Mike, and then real quick, and then we'll go from there. Okay. All right. So Francine, I'll kick this one over to you.
Okay. So there are gender differences, and cardiovascular disease is the biggest disease killer in America, including women. And I think that women are sometimes, it's less on our radar. We all get our mammograms and hopefully, and we're getting our, screenings. But when it comes to heart disease, some women tend to think that this is not their problem to worry about. And not that we should worry about it, but like everything else, we should have a baseline, and we should know what our risk factors are, our family history. There's a lot of genetic information out there now. And what I do tell women, there are people who will take, if they're having a hysterectomy, will say, just take everything out, the ovaries and the uterus. If you can hold on to your ovaries, if possible, if you're, there's always a risk and a benefit. What's the risk benefit ratio? They are cardioprotective, but obviously if you have, a lot of ovarian cancer in your family, or you've already had a reproductive cancer, and you want to remove them, that's fine. But then you just want to manage your other preventable risk factors as well. Also, women respond differently to medications because we have different body composition. So a lot of women I know will, maybe their LDL is creeping up and their doctor says that the statin is in their future. They don't want to go on the statin. They start out at, let's say 20 milligrams of Lipitor, and they're not tolerating it well. So then they quit completely and they come to me, right? And I don't ever want to have that on my back, right? So sometimes you may say, can we start at a lower dose? And I will still work with the patient, but just know that, it's not one or the other, that sometimes we do react even to the vaccines during with COVID. A lot of women were telling me they had, did not tolerate the vaccine as well as their husbands did. Maybe there's a big weight difference, and again, different body composition. We metabolize drugs differently. So those are things to keep in mind. Also, our vasculature is different because we're designed to reproduce. And so we tend to get sometimes different presentations. So different symptoms. I know women who've had cardiac events and tell me that they felt more like they had the flu. Maybe they had some neck or jaw pain, but not the crushing chest pains that you see that you would expect with the male pattern disease. So some things to keep in mind. And just as we're all out there wearing the pink ribbons in October and promoting and telling our friends, don't skip your mammogram, we want to be there for the other women in our lives, our sisters, our moms, and encourage them. And if they are getting fatigued, not hiking or doing strenuous exercise, but fatigue getting dressed, that's a red flag. I've seen that happen. Get them to get a cardiac workup. Next.
All Okay. All right. So just one last point that we're going to go through and do, and then we'll just kind of tie this in a little bit of hopefully a tightly knit bow for you all. And then we'll take a few questions. The correlation between osteoporosis and cardiovascular disease. All right. There is a link. All right. We've kind of been talking about lean body mass and body composition, all this stuff. There is a link between low bone mineral density and an elevated risk for cardiovascular risk factors in both men and women. Okay. So it's most common in postmenopausal. Those are just the individuals who are just more susceptible to developing osteoporosis, osteopenia. Okay. So just know, again, we don't have to go into some of these studies that kind of show correlations between, bone mineral loss in your heel bone and your forearm and all that stuff. Just know that if you are at risk and if you are osteopenic or osteoporotic, that your risk and elevation, or your risk is elevated for developing CVD. All right. So, again, working in a team approach, working with your primary care physician, your cardiologist, your endocrinologist, to develop a good, safe plan to, again, hopefully mitigate the potential effects of, what you may be predisposed to is just a good baseline. So just understanding that evidence. Okay. So tying this in a nutshell here for you guys, it's all about gene expression. Okay. So we kind of use that term epigenetics, at the beginning of this. Okay. It's epigenetics essentially is controlling the developmental gene expression and the signaling pathways. All right. So what does that mean in a nutshell? Everything we talked about tonight, okay, is a signal. Food, the way that you ingest it is a signal. Okay. What you ingest is a signal. Exercise, stress, all these different stimuluses that we put that we put into our system or onto our system are all just signals that hormonally our bodies respond to, and eventually our genes adapt to. Okay. So having the understanding and going into this process saying, hey, I have a family history of X. Yeah, that does put you at a predisposition to developing it. That just tells your system that if you keep doing probably the same stuff that your mom did, your dad did, your grandparents did, all that stuff, you're probably gonna, that's the definition of insanity, you're probably gonna follow the same path, right? However, if you change potentially what you eat from a nutritional standpoint, if you change the way that you kind of view fitness, if you change your sleep habits, if you alter these signals, the way that your system starts to code things changes, it alters. It may improve, and you may actually reduce your potential risk. So that's all that we have for you guys tonight. Thank you very much. We'll take a few questions if you guys are okay. I know we're a little over time. Does anybody have any pertinent questions? We'll maybe take a couple of minutes. Yeah, Mike.
Just one thing. And
Yeah.
Mind you, I've been through 10 nutritionists since 2015. And I also didn't hear this here, and I had to find this out myself, my own research a few years ago. The average person drinks and eats when they have a meal. Totally wrong. You're supposed to do all your drinking, whether it's water, milk, I don't care what it is, before you eat. One, it satiates you, tells your pituitary gland, so you know what, I'm full, so I'm not going to overeat. And if it's water, it's a half an hour or an hour before you actually lose weight. But it's interesting because you don't hear nutritionists hardly ever say that. They'll talk about everything from compound polyphenols, this, glycemia, all this other stuff, which is great, it's good. But when you actually eat, we're all predisposed to drink when we eat. It's totally wrong. You're not supposed to do that. I didn't know that until about maybe 2-3 years ago. Because I always thought you were supposed to drink that, each one goes hand in hand. It's totally wrong. You're never supposed to do that. But we grew up with all these, like you said, parents did it, grandparents did it, we're a product of our environment, right? So I just find it interesting, and I wasn't expecting to hear it here, but I guess I'm not surprised because the 10 nutritionists, and I'm not saying that, that this wasn't informative, maybe it just wasn't enough time into it, but it's rarely ever brought up. People really don't know that they shouldn't be drinking when they're eating. You should do it beforehand, and at least a good half an hour, 1 hour beforehand. And then it's not something that's commonly told. And again, I wasn't surprised to not hear it, but like I said, I've been through 10 nutritionists and none of them ever told that to you. So I guess I can't say that I'm surprised, But I would think that would be kind of important to tell people, because the average person really doesn't know that. They honestly, if you poll like 100 people, I'm willing to bet that 90 of them have no idea. They say, well, I never knew that. If I was a betting man, of course, I don't have that much money to play with. But if I was, I'd say 90 out of 100 would be like, what are you talking about?
Yeah.
I never knew that. So just interesting.
Yeah.
I just find that interesting,
Thank you for sharing that.
Yeah.
Yeah.
because you satiate yourself and you'll also lose weight and you won't overeat. So that gives you a plus, you'll get full faster. So interesting.
Great.
I just found it interesting and it wasn't brought up, but hey. So.
All right.
yeah.
I have a question for the doctor. You mentioned you do exercise on Tai Chi. My question, what's the different effects between Tai Chi and yoga?
Before I answer that, I'm not really sure that I can give you a great answer, but I will ask you this. Are you asking me from the perspective of the exercise benefit?
Yeah.
Or the whole body?
I don't know what's the difference.
In India, there is a word prana, and prana is life force energy. In Japan, they call it ki. In China, they call it chi. And essentially, life force energy is something, these are cultural beliefs, and you can get doctoral degrees in these things, where life force energy can be cultivated and regenerated depending upon how you live your life and how you move. In traditional Chinese medicine, which includes elements of Tai Chi, Qigong, as well as a variety of other things, some disease processes and disorders of the body are believed to be tied to inadequate or stoppage of flow of Qi, this life force energy that flows through these channels that are called meridians. Some of the belief of how acupuncture and dry needling work is based on the reestablishment of flow of Qi or Ki or Prana, call it whatever you want. That is in Eastern medicine. Yoga, Tai Chi, Qigong, they all are trying to bring you to the same principle of what we commonly call mindfulness. Not the thing that the 20-year-olds who are on social media all day talk about with mindfulness. Oh yeah, I'm doing mindfulness activities. No, they actually really do. Because when you're doing yoga, when you're doing Qigong, when you're doing Tai Chi, you're bringing your awareness to your body position. You're bringing awareness to which way you're moving and your breath. A good yoga practitioner who's experienced, their breath drives the movement. Most people who work in the gym, their exercise drives the breath. When people learn Tai Chi, Qigong, or yoga, and they've done it for some time, and then they go back and they do traditional gym exercise, their exercise improves. Because now they've learned a different way to have their body work. So you say, which is better, Tai Chi or yoga? I don't know that I can say that one is better than the other. I think that to a certain degree, they have overlapping benefits. I think that the exercise piece of yoga can be a little more complete than Tai Chi, because a lot of Tai Chi is mostly lower body, whereas yoga is upper body and lower body. I think they're both lacking in the perspective of both of them are only pushing, there's no point. And in any type of exercise that you do, there should be an element of both. What am I talking about? If you do push-ups on the ground, you're pushing your weight, but that's the opposite of rowing, which is pulling. In yoga and in Tai Chi, you're using body weight as your resistance, and that's all pull. All push, there's no pull. So from a strict perspective of balance, and in China they would talk about yin and yang, there seems to be missing an element of pulling against the pushing. But at the end of the day, doing yoga or doing Tai Chi are going to be much better than doing nothing. I can give you more information if you have more specific questions.
personally, I feel like Tai Chi, the movement will require connection, continuity. And the yoga, like one pose, one gesture, another one, like there is, what is it?
Clear beginning and clear end.
Yeah.
In Tai Chi, we're getting into a deep dive on this, and I don't know if you really wanted to do this. If you ever look at the symbol of Tai Chi, you have the yin and the yang. And if you look at the picture, the fat part of the yang is right next to the thin part of the yin. And the fat part of the yin is right next to the thin part of the yang. And you can't have one without the other. And where one starts, the other one ends. Why do I tell you this? Tai Chi, you're absolutely right. When you do your movements in Tai Chi, your whole body should move at the same time. You don't say, oh, let me do the arm movement and do the leg movement. They all go together. Because theoretically, the energy comes from the earth, not from the earth. In yoga, in many styles of yoga, you're right, where you have a clear beginning and a clear end to a pose or an asana. But there are styles of yoga where the movements are continuous. They call it flow or vinyasa. And there are a number of different styles of that, where you go from one position to another. That's a more advanced type of yoga for people who have more cardiovascular fitness and more strength. So.
Thank you. Very helpful.
So what happens if someone is a member of this club and you got other parts of the state? Are you a member of all of them?
Are you talking about our facility?
Yeah.
Yeah. So each facility has, it's one entity, right? So there's really not like a membership that we have so again, we have specific components of what we do like within each location, right? So each location has some sort of exercise specialty. Obviously we have, physical therapy, but we have exercise instructors and physiologists on site here that we run classes. We have programs. We do a diabetes specific program, osteoporotic program. We work very closely with the endocrine group next door. That may differ in a few of our other locations down in Westport. It's kind of like local relational ties that we have. But yeah, I mean, if you go into any of our facilities, you generally have access to a lot of what we kind of shared about with you today, whether it's exercise, some of the recovery tools such as the sauna, the cryotherapy. And if we don't have it on site, we have generally community partnerships that we can direct you toward. So there's not really like a membership, but for instance, here in Hamden, we don't have a cryogenic chamber or an infrared sauna. But if you wanted to travel down to our Westport office, we have it on site down there. Right. So you're more than happy to use our facilities, or we've got partnerships with a few locations that are locally that we've sent a lot of our clients to because we just believe in the ethos behind it. Right.
Insurance cover that.
So health insurance will go through, it obviously covers the physical therapy side of things. We have massage on site here. Typically what happens, massage is usually not a service. And let's use training as that as well. That's generally covered by insurances. But what you can go through and do, as long as it's kind of medically driven, especially on the massage side, for instance, what we do is we have individuals essentially render payment for the services, and then we give you a, essentially what's called like a super bill. So it's a receipt of payment with a medical diagnosis code that the individual then takes back to their insurance companies. And I would probably say like, 75-80% of people are getting reimbursed for those services. Yeah. So it's a lot of the time, it's not like a direct, it's hard to, like some insurances are a little different, but a lot of the time it's, there's services rendered up front and then reimbursements kind of given on the back end. So we can help you guys on, if you have questions on that, I'm the guy to get in touch with. I'd be more than happy to talk about.
That I could do, because if I get reimbursed for it, it's then I'm not really not paying anything.
Absolutely.
If you could, so that's something to delve into for sure.
Absolutely.
On a more specific one-on-one.
Great. Very nice. Yes.
Would you share the PowerPoint or this, so the information is very helpful?
Yeah. Yes, what we're gonna go through and do is we're gonna put together a little follow-up email for you all, okay? Which will have just some kind of like pertinent facts that we kind of went through and touched on today. So absolutely, we'll get you guys some information for sure.
I'll talk to you after. I'll
yeah.
get it for you.
Okay,
We had one question from Zoom land.
okay. All right.
Yeah.
Okay. Do you know why a person's throat becomes dry after waking up in the morning?
Their mouth is open.
That's right, exactly. So I mean, yeah, it could be a myriad of things,
Most
right?
people have mouth breathers. They're sleeping, their
Yes.
mouth is open.
Yeah, that's generally a very easy question to go through and answer. Yeah. So I mean, there's a myriad of factors. I mean, again, let's go back to the alcohol comment. You have a drink very close to bedtime, you can wake up with dry mouth, right? That's just, alcohol just kind of has, especially wine will go through and just kind of suck any salvo out. Most individuals are mouth breathers. That I think is probably the biggest answer. So I think we can kind of leave it at that. So
I heard the answer about that, use the tape.
yeah, mouth taping. Yeah, I've done it
And
before.
It's helpful.
It's quite horrifying initially when you do it because you think you're gonna die. Mouth taping. Yeah. So, all right. Thank you guys. Thank you very much, Dr. Rappel, Dr. Dinkler. All right.